Hello and welcome back to Pharmacology with Dr. Sokolow. So today we are going to talk about the third step of pharmacokinetic, which is metabolism. We already covered absorption and distribution, and so now let's move on to metabolism, which is the transformation of drug into metabolites that are more polar and therefore more likely to be excreted by the kidney, and that also going to prevent their reabsorption. So our body is really smart to get rid of chemicals and to protect ourselves against chemical. And because drugs are chemical, they are just going to be processed as any other chemical that would be attacking our system. And so that's why metabolism is there for, is to transform those chemical into inactive compounds that are going to be excreted. And what are the consequences of drug metabolism? So the first one, of course, is to make the metabolites more polar and inactive so they can be excreted faster by the kidney, so to promote the renal drug excretion. Another consequence is the inactivation of the drug. So here is an example. You have protein that is inactivated into PABA through the metabolizing enzyme. In most cases, drugs are going to be metabolized into inactive compounds, but in some cases, you can have an increase of effectiveness. The metabolites can have an increased activity. So this is the case in the example number 3, where codeine is metabolized into morphine. So both are analgesic. Codeine is weak analgesic compared to morphine. You know that morphine is very potent analgesic, and so codeine can be metabolized into morphine. And we are going to see what are the consequences in some patient where you have this metabolism that converts codeine into morphine. Now, in the example number 4, you have the inactivation of a prodrug. So, as opposed to number 3, so number 3, you have a drug that is already active but has, less activity that is metabolites. A prodrug is a drug that doesn't have any pharmacological effect unless it's converted into the active drug by metabolism, by the metabolizing enzyme. So here is an example. So this is prazepam that is metabolized into desmethyldiazepam. In this desmethyldiazepam is the active drug. And that's why a prodrug doesn't have any effect and it has to be converted into the active drug. And so these are anxiolytic and they also have like some sleep aids effect. And so for this prazepam to be active, it has to be metabolized. And then the last consequences of drug metabolism is an increase in drug toxicity. So of course we don't want that, but that can happen. And for example, with acetaminophen or your Tylenol, that is a pretty safe drug unless it's used at high dose and on a chronic basis for a patient who has, chronic pain that can occur. And that's why there are recommendations of not taking more than 2 grams of Tylenol per day and also to limit the use of Tylenol over time. Because what happens is like the enzyme that usually metabolize Tylenol in the body are getting saturated, and there is a second pathway which only represent 5% of the pathways of metabolizing pathways of Tylenol. But with that pathways, it leads to an hepatotoxic metabolites, and that's why you can see some hepatotoxicity with Tylenol at high dose. Now, what are other considerations that we need to know about drug metabolism? The first one is age. So, as you know, young patients don't have a liver capacity that is fully developed, and so that's why young patients are being given low dose of a drug because their enzymatic system, their liver function is not fully developed, and therefore they need smaller dose of medication. Elderly, on the other hand, their liver, function so much through their life that their liver capacity is actually reduced, and in some case, in some elderly patient that has hepatic dysfunction, you are going to want to adjust the dose in those patients. Now, drug interaction is very common, and of course, we try to avoid those drug interaction, and we try to avoid giving two medication that can interact with each other. But in some case, we don't have a choice, and we have to know that if there is a drug interaction, that we may have to adjust the dosing of one or the other drug. What are the type of drug interaction? You have two type. The first one is either an induction or inhibition of the drug metabolizing enzyme. So in that case, they say you have drug A and drug B. If drug B is metabolized by an enzyme that can be activated by drug A, you're going to have less effect of drug B. And so we're going to see a lot of example when we are in class, because I really want you to understand that process of drug interaction. And I'm going to cover this in the coming slide, but also I will be covering in class. Another way two drugs can interact is like they compete for the same enzyme. And so if the enzyme is being saturated because both drugs, are being metabolized by the same enzyme, then you have a drug, one of the drug is going to stay longer in the system than the other. And then the first pass effect, um, I talk about this in one of the previous module, which is the rapid inactivation of certain drug by the liver. So if the drug reached the liver before reaching the target, then you're going to have a smaller effect or no effect. And that first pass effect, of course, is well studied during the clinical trial and also during the preclinical trial phases to understand better how a drug is metabolized. And then the manufacturer and the pharmaceutical company, when they get approval for that drug, they know how much a drug can have a first pass effect and which dose is optimal for the treatment. But of course, if the patient has an impaired liver function and is taking a drug that is heavily has a heavy first pass effect, you can see also some toxicity in that case, as the liver is not going to process that drug as much in patient with liver dysfunction. But so the first pass effect is like the rapid inactivation of certain drug before they can even have reached their target. An example, for example, nitroglycerin. They are given sublingually to bypass the liver because otherwise it would be inactivated and have no effect. Now, where are those drugs metabolized in the liver and how? So drugs are metabolized by the microsomal oxidase system, and there are like two steps. We have the phase one reaction, and then you have the phase two reaction. The phase one reaction are the functionalization, and in that case you have a drug that is becoming more polar. You have an addition of a function. When I mean function, it's an organic function, it's organic chemistry, and the function like an oxidation. And so you have a drug that is becoming more polar and going to be is going to be better for its excretion by the kidney. And so the system, the enzyme that are performing those metabolizing process are called the hepatic microsomal enzyme system, and they're also known as the P450 system. There are three main CYP enzyme families, which are the CYP1, CYP2, CYP3. And then within those three families, you have subfamilies like the CYP2D6, CYP3A4, which metabolize most of the drug. I'm not going to ask you to memorize which drug is metabolized by which family of enzyme, but I want you to understand what can happen if you have two drugs that are affected by those metabolizing enzyme. Because when I have examples showing you how those interaction can occur, the results of those metabolizing enzyme are going to lead to more they're going to be more active on lipid soluble drug, but as we studied before, we know that drug has to be somehow lipid soluble in order to cross the membranes, and those who has to cross the blood brain barrier are going to be even more lipid soluble, and the end product, the metabolic product, of course, are usually less active. So now let's go back to those three type of SIP enzyme. They have different substrate. This, I have to maybe send you back to your biochemistry course when you studied, enzyme substrate. So they are gonna, like drugs are gonna be metabolized by some of those enzymes, and the most abundant one is the CYP3A4 enzyme. And so if you have two drugs that are metabolized by the same enzyme, or if you have one that is inducing one of those CYP3A4 enzyme, is going to lead to the degradation, to a faster degradation of another drug that may be metabolized by that CYP3A4 enzyme. So those enzymes are very well studied in, for their genetics, because they are like polymorphism that are studied and that can lead to the differences in drug response in patient because of their genetic. Their enzyme can be working faster in some patient, and in some other patient, because of their genetic, it can be slower. And also based on ethnicities, we found that some of those enzymes are working differently in different ethnicities. So for example, here I have the CYP2D6 enzyme, and their pharmacogenomic or pharmacogenetics showed that Asian are poor metabolizers, Caucasian are intermediate metabolizer, and Ethiopians are ultra metabolizers. What does that mean? That means if you have um, Asian patient who's taking a drug, like let's say like an antidepressant, because they are poor metabolizer, that means it's going to take longer for the drug to be processed, so it's going to stay longer in the system, and then the effect is going to remain longer. But you can also have the occurrence of adverse effect because it's still longer in their system. So in poor metabolizer, maybe a reduced dose is going to be necessary in order to avoid adverse effect. And again, I will be covering this topic in class to make sure you understand it. And then also the FDA issued a warning several years ago about the coating product used in nursing mothers. So mothers that are breastfeeding their baby and are taking codeine, it can be a risk for their babies. So if you have, for example, ultra metabolizer in that case. So if you remember in the previous slide, I said that codeine is converted into morphine through those metabolizing enzyme. Now, if you have a patient that is an ultra metabolizer, that means it's going to metabolize faster codeine into morphine, and you give this to a nursing mother, which is going to be passed into the milk to their newborn. If there is an increase of morphine in their system, that can lead to toxicity, And in that situation is not the analgesic effect that we're going to be worried about, but is the respiratory depression that can occur with high dose of morphine. And so in the baby that can cause respiratory depression and respiratory distress. So that's why there was a black box warning. So that means a big warning on the data label to be careful for breastfeeding mother, because there is an increased risk in ultra metabolizers, so those who metabolize faster and convert faster codeine into morphine. Now, the concept that I'm talking about that is very important and that sometimes is hard to grasp is the concept of inducer and inhibitor um, of the CYP enzyme. So when you say inducer, that means it's increase the metabolism of the drug, because let's say drug A is going to bind to the CYP enzyme, and I always like refer to a Pac-Man. So when drug A bind to the Pac-Man, then the Pac-Man is gonna start biting faster drug B, in which means you're gonna have less of drug B faster because of the inducer. So the inducer is the one that binds to the Pac-Man and activates that Pac-Man. And drug B is the one that is affected because the Pac-Man is now going like crazy and going fast. So you have a reduction of the concentration of the drug. They say so that would be the inducer, which is A, is going to reduce the concentration of drug B and therefore reduce the half-life, so the time that drug B remain in the body. And of course, it's going to reduce the efficacy of drug B. So here is some example, which is carbamazepine and estrogen. So carbamazepine is an anti-epileptic drug, and estrogen, can be used as an oral contraceptive. So if you have carbamazepine that is given, to a woman who is taking an oral contraceptive, they have to be careful because carbamazepine is going to activate the Pac-Man that is going to eat up the estrogen faster, and which means the estrogen level is going to be lower than what you expect. And the consequence is like a woman who is taking both can become pregnant because now her estrogen are not the level are not high enough and are not protecting her from not becoming pregnant if she was using it as an oral contraceptive. Same with St. John's wort, which is an over-the-counter medication that is used that has some antidepressant effect. And so, same thing, you can have a woman who's taking an oral contraceptive and so not feeling well, especially now during quarantine. We have a lot of moods, or mood is affected, and some, patient, want to go see a doctor and decide, oh, I'm going to try St. John wort. And they are on a contraceptive and they don't know that there is an interaction between the two. And surprise, they can become pregnant because of that interaction. So St. John wort is the inducer of the CYP enzyme. So see the CYP enzyme as the Pac-Man. Once St. John's wort activate the Pac-Man is gonna eat up estrogen, which is drug B, and then you have lower level of estrogen and lower efficacy. Now, on the other side, you have the inhibitors of the Pac-Man. And in that case, when you have drug A that bind to your Pac-Man, and then the Pac-Man is going to go slow and slow to eat drug B, you have more of the drug B that stays in the system. So you have a higher drug plasma concentration. The half-life, so the time the drug B stays in the body is going to be extended, and you have an increased risk of toxicity. Here are some other examples. So clarithromycin, which is an antibiotic, and ketoconazole, which is antifungal. So you have clarithromycin that is gonna slow down the Pac-Man and is slowing down, and so then ketoconazole is being eaten up slower than usual, and then you have more ketoconazole that stays in the body. And one of the adverse effects of ketoconazole is an increased risk of QT prolongation and torsade de pointe, which is a cardiac condition that can be lethal. So this interaction is more severe than of course, if you don't want to become pregnant and you become pregnant, that can be a problem. But with the clarithromycin ketoconazole interaction, it can lead to a cardiac arrest. Now, another example is ritonavir and lopinavir. This one, it's actually a good interaction and it's used in HIV/AIDS medication. So when they are used in combination, actually it helps reduce the dose of lopinavir that is given to the patient. And because lopinavir has, a lot of side effects, by giving those two drugs together, you can reduce the dose of lopinavir that the patient is taken. So again, ritonavir is the inhibitor of the enzyme. So enzyme is your CYP or your Pac-Man, and lopinavir is the substrate. So once ritonavir is binding to your Pac-Man, you start going slower, and then it's up lopinavir um, less rapidly, and then in that case you have more lopinavir that remain in the system, and that help reducing the dose of lopinavir that has to be given. Again, this concept will be discussed in class, and we'll have example and exercise for you to make sure that you can practice and you can understand. And if you want to practice, you can also look at table 6.1 in your textbook and look which drug is a substrate and which drug is either an inhibitor or an inducer of those different CYP enzymes. And so we talk about phase one reaction, and then you have phase two reaction by those CYP enzyme. Those phase two reaction are called the conjugation reaction, and it's a conjugation with an endogenous substance like glucuronic acid, a glycine, and so that substance is added to the drug and make a drug conjugate again that is more polar and that is going to be excreted faster through the kidney. Those enzymes are called the transferase, and they are relatively faster than the P50 catalyzed reaction. So here is a slide that shows the two phases of the metabolism of aspirin. So you see here you have phase one, and you have like different type of enzyme, that are working on aspirin. Sometimes you don't just have like one enzyme that is going to lead to one type of metabolite. You have like several enzymes that work together and do different things. So you can have oxidation, hydroxylation, dealkylation, deamination, hydrolysis. So you remember I said phase one is the functionalization. And here you see aspirin is metabolized in a derivative, so in a metabolite. You see that this function was removed, and now you have an OH on this derivative, which is more polar. And then the phase two, which is a conjugation. And so here you have that big glucuronate that was added, that was conjugated to this salicylic acid, to that derivative of aspirin, into a bigger, more polar metabolite that will be excreted by the kidney. And so this shows you step one and step two reaction for the drug. So in this case is aspirin. And this is it for this third step of pharmacokinetic, and I will see you soon for step 4 and the last one of pharmacokinetic. Stay well and stay safe.